If you haven't noticed over the past 10 years, our reimbursement rates haven't gone up. I want to talk to you today about a new value proposition in care. And we're also going to talk to some experts about these emerging models of care and this new value proposition. Our current payment model is based off market share, volume, growth, and contract price. That's when they brought pharmacy benefit managers in a few years ago. The pharmacy benefit managers were dispatched to lower this rising drug cost. So it siloed pharmacy out of the healthcare system and put us in our own box with our own payment system. So we were siloed out of the non-drug benefit. And this ultimately siloed out our entire profession into a filling prescriptions, fast, accurately, and cheap, high volume model. So now we're at the crossroads of volume and value. Where do we divide the two? How do we get into the value workspace, and how do we get compensated to do this? I've been told by payers time and time again, we're not going to pay you anymore, but we may pay you differently. So how do we get into that different payment model? So the real thing to get in the new payment model is the triple aim. It's cost of care, quality of care, and access of care for those patients. If our current model is volume-based, then our future model is based on quality, efficiency, partnerships, improving population health, per capita cost, and services. What is value? Value is the health outcomes achieved divided by the number of dollars over that cost of care cycle. So how do we move over to that value cycle? Well, payers are helping us do that by pushing risk down to providers. They're telling providers they have to perform, they have to give us outcomes, or you're going to take a financial hit if you don't. So this is pushing us into the corner to start population management strategies. We're no longer just concerned about that patient standing right there in front of us. We want to know what happened to that patient before they ever came to us, what's happening while they're there, and what happens after they leave our pharmacy. So this kind of aligns us with a completely different payment strategy. In pharmacy, we've always been paid at the point of encounter. You dispense a prescription, you get paid for that prescription. You don't dispense it, you don't get paid for it. Where the new model of care looks at the pre-encounter, as well as the encounter and the post-encounter, and it also looks at those patients that are completely disengaged from the system. And there's payment along all four of those boxes. The pre-encounter would be paying you to take care of a patient or paying you to look out for patients who may be at risk. The encounter would be paying you to dispense that medication and maybe paying you to deliver some type of MTM activity or adherence monitoring. Where post-encounter may be the follow-up. And what are you doing 2 weeks after they were dispensed that medication to ensure that they're not having any problems with that medication, and that they're taking that medicine like they should, and encouraging and coaching the patient about disease state and about non-drug therapy things they can do. Then there's the population that's disengaged from the system altogether. They may be showing up to you to get their hydrocodone filled each month, but they're not filling their medication for diabetes. They're not filling their medication for COPD or anxiety. So this shift from the fee-for-service model where you are paid strictly for the encounter to the model where you're paid some for pre-encounter, some for encounter, some for post-encounter, and some for the disengaged is now the population-based management model where you're paid across that entire spectrum. So this forces you to work with all healthcare providers and communicate with all healthcare providers across the whole healthcare spectrum. So we're all reinforcing that care plan. The care plan that the physician has outlined is the same care plan that I'm telling them in my pharmacy every time they're coming to visit, is the same care plan that my technician is reinforcing when they're talking to them on the telephone. Same care plan that your care manager is reinforcing when they're in the home doing the home visit. We talked about the 4 stages of encounter, but what about the outcomes measurement? We're not just filling prescription written rate versus prescription filled rate, but now we may be accountable for a heart attack rate. So we've got to ensure that that patient is taking the right medication and actually taking it like they should be. Those are some opportunities for community pharmacy. But one of the real opportunities for us is not how do we improve our metrics, but how do we improve other people in the healthcare team, how do we improve their metrics? So how do we as community pharmacy rebrand ourselves? How do we let people know of the value we bring to the system? We've done a great job over the years of telling each other how good a job we do at taking care of our patients. But we haven't done such a good job of telling everybody else, telling the public how good a job we do at taking care of patients, or telling other healthcare providers and other members of the healthcare team how good a job we do of taking care of our patients. So in this rebranding model, we've got to think of pharmacy as an investment, not a cost center for healthcare. So I want you to repeat that after me. Pharmacy is an investment, not a cost center. That's the idea that I want you to focus on and get that message across. Tell that story to everyone out there. Tell that story to payers, tell that story to patients, tell that story to other healthcare providers. So in this rebranding of community pharmacy and rebranding our new opportunities, we should look to the referral process as a great opportunity for community pharmacy. So we used to place ads to try to drive patients into our pharmacy. Now we use quality and outcomes as our driver for referrals to bring us new patients to our pharmacy. So you don't go to the doctor and the doctor says, hey, I think you need a hip replacement, and go get you one and then leaves you alone. He says, I think you need a hip replacement, and you probably want to see Dr. Smith. He's one of the best orthopedic surgeons around. He does a lot of hips, and he'll really treat you right. And then your doctor and Dr. Smith communicate about what's going to happen before the procedure, during the procedure, and after the procedure. We need to get community pharmacy operating the same way. Hey, this doctor has a very complex patient with multiple needs. I need to find a pharmacy who does those service sets. Maybe it's delivery, maybe it's synchronization, maybe it's packaging in a certain way. But that pharmacy knows when I refer this patient who's very complex to this pharmacy, they'll take care of all their needs. And they'll communicate with me when there's a breakdown in these needs or when there's a new development that the patient needs. And it becomes that two-way street again. So I think our new model is how do we drive referrals to us? And we drive those referrals through the quality. So if quality is that focus for the referral, then we're accountable for that. And we'll start getting measured on our quality. And this makes us maybe a little uncomfortable, but that's the new world. Amazon has ratings on their page, Medicare has their 5-star rating system, and pharmacies may be rated on their ability to give them the outcomes that they want to help these different healthcare entities meet the metrics that they're being graded on. Recognizing the importance of a referral system, of identifying a patient with a need and connecting them with someone who can do something about that need, identifying a problem and connecting them with someone in the healthcare spectrum that can actually help resolve that problem is very important. So Community Care Network of North Carolina, in partnership with the Centers for Medicare and Medicaid Innovations, has developed a Community Pharmacy Enhanced Services Network. This network of high-performing pharmacies is available to CCNC, whose robust analytics will identify patients who are at high risk of rehospitalization or high risk of adverse events. CCNC's analytics will identify patients who are at high risk of rehospitalization or high risk of adverse events and connect those to pharmacies who can fill the needs that they need. The pharmacy also communicates back with CCNC through a portal they have developed, as well as the care managers can communicate through this portal. So we now have the whole team talking to each other, and the learnings that come out of this grant from Centers for Medicare and Medicaid Innovation will be used to find out what are best practices for community pharmacy and getting them the outcomes that they want. We're learning a lot of great things from the Community Pharmacy Enhanced Service Network about how to divide out the workforce in pharmacy to deliver the most efficient care that we can, to deliver the outcomes that we want. We're learning things, like I mentioned earlier, about the connection the community pharmacist with someone else on the healthcare team may be as important as a connection of the community pharmacist with the patient face-to-face. We're learning things like a lot of the value that we bring may not be just clinical measures. They may be measures like, can I help the patient by delivering their medication, giving them access to care. They weren't taking their medication and we can deliver it to them. So that's not necessarily a clinical monitoring tool, but it is a pharmacy care coordination metric that we can measure. So we're learning that there are a lot of non-clinical activities that really bring value to the payers. So community pharmacy is in an excellent position to deliver that type of coordination. So now we will hear from some other healthcare professionals on how they're connecting with the Community Pharmacy Enhanced Services Network to give a better coordination of care.
The community pharmacists are definitely a partner that we've been looking for a while. Our case managers have very complex patients that they often refer to these pharmacies for services that they can't get at other pharmacies, like delivery, comprehensive medication review, adherence packaging, as well as, sort of having a more personal level of service. I think as we send them more complex patients, we can be partners with them in managing these patients to sort of bend the cost curve and improve outcomes.
With medicine, we've often worked in silos. Patients are actually going to the community pharmacies. The community pharmacy is just that, it's sitting in the community. So they know the patients who are coming into their pharmacy, but they're also in the community and they know the population that they're serving and the struggles or the access problems that they may have. And so sometimes they are actually providing more services to their population because they have a better understanding of their population. I think trying to get the word out then to the local behavioral health providers, I think, is key to this because I think they need to understand the service that these pharmacies can provide to their patients.
When you look at what are the issues for a patient, medications are always popping up. When we look at moving patients out of the hospital into home, most of the reasons they're readmitted is around some issue with their medication. The hospital didn't realize they were on certain meds at home that didn't get identified or whatever the issue might be. So it's amazing to be able to think that we can bring in a network of pharmacists which add to our resources to help our care managers around medication management and make a connection there with a care manager. We can provide them information on that patient with our informatics. They now have the ability to go in and look at what that patient's doing in terms of ED utilization. Are they filling their scripts? That's pretty amazing to be able to see that whether patients filling their prescriptions or not. And so I think we're going to help that pharmacist help us because we're giving him better information about the patient.
I have been impressed with these pharmacies in their ability to work with us, or their willingness to work with us, their innovativeness. I guess that's the thing that sets them apart from some of the other pharmacies is they're willing to do innovative things. The payment system, the way it is in community pharmacy, they're constantly looking for ways to bring in additional revenue and look for additional sources, even clinical programs that they can be involved with that both increase the amount of reimbursement that's coming in the pharmacy, but also the quality of the services they deliver. So I've been impressed with that. Some of the hurdles we've experienced primarily are just around technology. There's been a little bit of a learning curve with the documentation around comprehensive medication reviews. And
I think when it comes to the folks with behavioral health disorders, particularly those that have serious and persistent mental illness, people with schizophrenia, severe bipolar disorder, severe depression, are often on the outside of the care system. They aren't always welcomed in the primary care office. And then you have the other leg of the stool, which is the pharmacists who are out there and probably see those folks more than the primary care physician. And then you have the psychiatrist who, because of the workforce issues, may not see those patients except once every 3 months or so. So they're really outside the system, and it calls for better coordination of care. So the community pharmacist is the person that can be at the hub of all this, watching over medications, looking for the beginnings of difficulties with the patient, and is able to communicate with the physician, communicate with the psychiatrist physician, and hopefully help these folks stay kind of inside the system instead of being outside the system.
And that one of the biggest challenges facing this population is that generally, by definition, they're going to have multiple prescribers. So one of the biggest drivers of readmissions and medical errors is multiple prescribers who don't communicate. So the pharmacists in these enhanced settings are going to have a unique opportunity to watch for contraindications and identify potentially dangerous areas for this vulnerable population.
We just heard how the CPESN was integrating with other healthcare professionals to deliver care where it's needed most. CCNC has analytics that will identify those patients that are most at risk. So we're not focusing our effort across every patient that has diabetes. We're focusing our effort off those patients who need the care the most. So there's a big difference between the 55-year-old male who's very active, who was just diagnosed with diabetes, than the 55-year-old male who's had diabetes, not taking anything for it, and had 3 hospitalizations in the last 365 days. So if we want to save the system money, we focus on that second individual that's a high-cost individual to the system. If we want to have better metrics and better quality metrics, we focus on the first individual who we have ability to influence and keep their hemoglobin A1C down low. So by knowing where to spend our calories, where to place our workload, so we can give the payer the outcomes they want to enhance their metrics. I want you to walk away with pharmacy is an investment, not a cost center to drive outcomes for other healthcare providers. I also want to thank you for joining me for this CE program. Make sure and check out ncpanet.org for other information, and come join me at the next NCPA conference.